Thank all of our panelists. This has been a terrific panel and brought up a lot of really provocative questions about the effects of poverty and the roles of caregivers in children's development. Before we open the floor, do any of the panelists have questions for one another? Please.
Maybe more of a comment. I was delighted to hear that cement floors and a bit of cash goes a long way in helping depressed mothers. But I mean, the comment is that I treated maternal depression as an outcome, but it can also be a very useful marker of adversity that impacts on child development. So all of these things like low socioeconomic status, increased HIV, humanitarian crisis that the previous panel, we've done some studies, increased violence, reduced empowerment, reduced support, all of these things which contribute to maternal depression, and then maternal depression is a marker. And if you operate at the risk factor level of what flares up depression, you could also impact depression. So I'm not surprised. The second thing that might be very important in cash transfers and how it impacts on other programmatic outcomes. The thing we struggle with in our programs is engagement. How do you get families to engage with the program? It's so hard. And we've been trying to be, child development is a wonderful vehicle. People really engage with child development. They want to see their kids grow up to be bright. They're not interested in survival, they're interested in bright kids.
They're not interested in height either.
So child development for us, I mean, that's our Trojan horse. We don't talk about depression, we talk about child development. And cash is a wonderful, powerful engager. And I wonder if engagement is a moderator of the impact, that many of the programs are having. So just a couple of comments.
I think it's a great point. I just add about engagement that this was the first time we had played around with whether or not something was required as part of the conditional cash transfer program, and we did find that there was no difference. When we offered the maternal support groups in the voluntary approach, there was no difference between that and the control group, as you saw. It was just when it was compulsory. So it does suggest that it's the worst, maybe it's the worst way to get engagement, is to say it's required as part of your cash transfer. But our results suggest that there was only significant findings when it was tied to the receipt of cash and not when it was just voluntarily available in the community. So it's a great point, and it's a real question. I think I would love to talk to you about figuring out a way to alleviate maternal depression as its own intervention and thinking about how we could do that with cash transfers. Okay, another day we'll talk about that.
Any other questions on the panel? All right, before we open to the floor, I'd just like to remind everyone, please use microphones because of translation and folks who are remote. 1, 2. Oops.
So just wanted to make a comment about, excellent presentations and quite relevant, and it is really where we are today. I work in sub-Saharan Africa. For several years I have been working on mothers and children. The problem with mothers and children, first of all, mental health and child development, problems with how to evaluate or just to know how much developmental delays exist in these communities. The more we look at it, the more we find it. So mental health, maternal depression, postpartum depression, and so forth is quite prevalent. The problem is how the policy aspects of these is the challenge. These maternal health and mental health problems, child development, they are in no one is taking care of them. I mean, if you look at clinical disciplines, public health, where do they belong? So it is not clear today, for example. We know what has happened after HIV. They have survived and they have come to this point. But where mental health, be that for adults or for children, developmental delays and so forth, it belongs to no one. Neither clinical disciplines within the ministries of health or the hospitals, clinicians, academicians in Africa. It is just difficult to know where they belong. So I think that is the first thing that needs to be defined, that as a category, mental health has to be either as a separate discipline, or if it belongs to clinical medicine or to internal medicine, ops anxiety, or wherever it is, there has to be a clear distinction so that someone is worrying about these women and children.
Thank you. Two comments. One pertains to maternal mental health, and since Atif and I work in the same geography, although different provinces, one big issue that I've struggled with is where do you draw the line between mental health issues that you discern in community settings, and the unspoken word around domestic violence and discrimination. So I'd like to hear from Atif what his experience has been. I mean, the recent DHS survey, for example, from Pakistan has opened many eyes because it specifically had a module around violence and indicated the close overlap between these two issues. And you clearly do not have a straightforward solution to one or the other. And if we are going to get into this space, then we also need to bring in issues of empowerment, engaging men, particularly engaging communities in general around those issues. The second question that I have for you, Liz, is around unconditional cash transfers. So what is the global evidence supportive of conditionalities around cash transfers, especially given that many countries have opted for the latter, which is unconditional cash transfers? And is there any evidence that one or the other is superior in terms of developmental outcomes?
Before we take more questions,
Okay, I'll address the question about who owns mental health. The point I was trying to make in my presentation was that it shouldn't be one particular group. It should be all of these groups should take ownership of mental health, because you can't dichotomize mental and physical health and development. And the second point is that it should be, it's quite straightforward. You can have a components-based approach. You can deconstruct the interventions that mental health people do and see that they make sense to a lot of other people who do other programs. And then you just sort of enhance those components, which are sort of so-called mental health components, if you see what I mean. So it's not a separate vertical program. By no means it should be. It should be an integrated approach, and it should be deconstructing everything and then putting it together again so that it works well. And that partly relates to the question that Zulfi's raised. What are these things are so interlinked. Empowerment, domestic violence. One of our 5 pillars is family psychoeducation, family education. You start gently to address these issues, possibly through the vehicle of child development. What's best for this child? And people will start to engage, and so we have these very important critical allies. So the husband, the mother-in-laws, they're very important power brokers within the family dynamics. Engaging them is critical. You do it through, we haven't tried to do it directly, hitting is bad, and, we try to do it through optimal child development, the environment that's needed for optimal child development, looking after the mother, and what are the factors, how can you do that, and how can the family work together. That's, we feel, our best hope of trying to address these issues of violence and empowerment at the moment. But of course, there can be other interventions like, conditional cash transfers can be a powerful, additional tool, and I'll let you talk about it.
We did a study in Ecuador looking at the participation in the unconditional cash transfer program and did find reductions in domestic violence. But it was a modified effect which had specifically to do with the differential in education between the partners, between the male and the female partners. So that this relates actually then to the question of who in the household gets the money. And when you look at, for example, microcredit programs, the picture is not as clear looking at depressive outcomes, I'm sure you know these studies that show that microcredit programs sometimes actually, we did a study in South Africa showing that while depressive symptoms went down, perceived stress went up, and because there's a component of having to pay it back, and so there are economic approaches that can end up leaving you in a situation where the mental health can be compromised because you're putting them in a situation where they have to pay back the loan. So to get to your question, it's a great question about the conditional versus the unconditional, with one preface, which is the unconditional cash transfers are so much logistically easier than conditional cash transfer programs. I just want to make that point, which is why there's so much interest now in the unconditional. For example, this organization in Kenya that's looking at using global mapping to look at the roof quality as a proxy for poverty and then providing cash transfers to people with lower quality roofs. It just doesn't have the kind of complexity of the administration of the cash through a conditional cash transfer program. When I think about the complexities of the Mexican program, the doctors are recording visits, the teachers are recording whether kids are in school, all of that compliance has to then be fed back to a central monitoring system, which then confirms that a family is eligible to receive the transfer or not. But so, in answer to your question, it completely depends on what outcome you're looking at. So a recent meta-analysis found no real differences in terms of height. No real differences in terms of CCTs versus UCTs in terms of height for age outcome. Now, your meta-analysis that looked at breastfeeding and vaccination found that there were differences, that the conditional cash transfer, as you know, showed was associated with better outcomes in terms, better breastfeeding rates and better vaccination rates. There are only a couple studies that have looked, so that's looking, for example, at meta-analyses and saying, let's compare those studies that were the UCTs versus the CCTs. Now, the studies that have compared them head to head, let's have an arm that's a UCT and an arm that's a CCT, have unfortunately not been as clear as we would like to see. So, for example, in the Zimbabwe study that had a UCT arm and a CCT arm, there was an increase in birth registration rates in the CCT arm, and that you didn't see in the UCT arm, but then the vaccination rates, there was no difference. So, and then similarly in the Malawi study, there was the effect of the CCT on increasing school enrollment in the adolescents, but not in the UCT. So I would say the major answer to your question is it completely depends on the outcome, and also that it's an area that's really open for research, is head-to-head comparing a CCT and UCT within the same study.
Comment from Lorraine.
She has two questions. The first is for Dr. Rahman. Could you comment on the importance of paternal depression, both in conjunction with maternal depression or on its own? Emerging literature shows prevalence and effect. And the second question is for Dr. Fernald. Thank you for a considered overview of cash transfers. We are looking at combination interventions and specifically at adolescent risk outcomes and exploring the effects of cash plus care, finding a considerable advantage for both boys and girls of adding care to the cash component. Has this been tried in Mexico? Thank you.
Yeah, I think it's a very good question, and paternal depression is important. We haven't actually studied it as much. Some other groups have and found it to be quite prevalent and important. It should be addressed. That's all I can say at this stage.
I don't know that that's been done in Mexico. The only areas that I know of that are doing that, this question about the adolescent risk outcomes with care, those are mostly occurring in sub-Saharan Africa. Those are the studies that I'm aware of in Tanzania and Malawi and Zimbabwe. But I'm not aware of that approach being used in Mexico.
Yeah, thanks. That was a really interesting overview of the CCTs. Now, is there, of course, to run the unconditional against the conditional is kind of difficult because if one group knows they're being measured against a set of outcomes, I mean, there is certainly a Hawthorne effect, which you can't really, you'd have to do almost the same replication for the unconditional, but somehow, so you don't know if it's actually the conditionality that's making a difference or the fact that they are actually getting measured that's making the difference. The second is for the thing about maternal depression and the living wage, for instance, that was interesting. Now, was that done in a cluster randomized kind of fashion, or did you just pick individuals in the factory and then they got a higher wage? And I mean, did that lead to higher depression against the folks who didn't get the higher wage? Because, you know, it was done in the cluster, okay. Because, you know, everyone got it, okay, that's great. You know, because there is a literature on people actually feeling better if they're doing better than everyone else around them, all else being equal. So people are, you know, might opt for a low wage as long as they're actually, you know, wealthier than the other folks. The last thing is you know, thinking of sort of, again, the scaling up issue, and I'm thinking of course, the parallel with pay for performance. You end up paying a lot of people to do things that they would have done regardless. How much of that would really be an issue here when you think of sort of, say, benefit cost ratios, for instance, when you look at this? And also, I think in one study you had mentioned what you found with respect to who actually improved their performance because of the conditional cash transfer, and you said, well, it was the kids who were doing the worst. Is that typically true, or are there studies which actually look at people who do meet the conditionalities and how they differ from those who do not meet the conditionalities?
We'll take the two last questions, and then we have to wrap up.
So this is a question as well as a statement, and I just want to just make sure that is clear. I think from our perspective, you know, developmental disabilities like autism is often classified as mental health issues, mental health challenges. So the question is for the panel is that the strategy, I know some answer from this already, I know, for example, Atif, the strategy that you articulated, how does that apply to families or caregivers for children with disabilities?
Two more.
Okay. No, go ahead, take the
Do you want to answer? Okay. So I just wanted to get a little more conversation about the issue of work-related income versus cash transfers. So we actually do have a mechanism for increasing work income. That's increasing the minimum wage. It has an effect on the informal economy in most countries by raising the shadow minimum wage. Maybe you could talk about what is known about the relative impact of increasing actual earnings either in the formal or informal economy.
Okay, I think unfortunately this is it. So.
I'll address Andy's question. We're doing a project on disabilities, you know, intellectual disabilities, again using family members and volunteers from within families who are trained then to deal, you know, to train other family members. This is a project funded by the Grand Challenges. And here we again keep maternal stress or parental stress actually, because having a child with a disability is a big stress factor for parents, and they have higher scores on distress and mental distress than the normal population, even higher. So it's a critical intervention. We're also following the MHGAP guidelines, the WHO MHGAP guidelines, which has clear specific instructions for addressing maternal stress or parental stress. And so you can't do a program without addressing this. And so again, using the same sort of principle that I outlined in my talk, we are integrating them within the disability management, but we are doing it through family volunteers who then train other family volunteers and form support groups for each other. And so we have champions who then sort of make sure that these groups take place. You give the champions some cash so that they're motivated. They try and engage other family members. And parental stress is a key intervention that is addressed through social support and supporting each other in that way. So that's one example of how one could go about addressing this. In places where there are very scarce resources and specialist care is not available.
Just to add that most of the issues that came up with the HIV caregiving would actually translate to children and families with children with disabilities. So they would face the same stressors, they would face stigma and all that. And I think that caregivers' mental health is always challenged. And I guess programs that intervene in such families need to be holistic, try to attend to all the various issues of poverty, mental health, and caregiver stresses.
I'll answer the questions about the CCT and then the living wage. So I wanted to get at your question of the CCT versus the UCT and the challenges with having a multi-arm trial like that. But telling you an anecdote about our Ecuador analysis, which was, it was a UCT, but it had originally been a CCT. So there was a portion of the population that believed it was a CCT. And we actually did a subgroup analysis on them after our main analysis and found that there were height effects in that CCT group, the group that believed it was a CCT, and not the group that thought it was a UCT. So that's just something to throw out there. Not that you would want to use deceit in that way. That was an accidental deceit situation because the program had been designed one way and rolled out another way. So the other thing I wanted to mention is about the disadvantaged children. The meta-analysis that I mentioned about height and the meta-analysis about CCTs and UCTs and their effects on height showed that there was a significant effect on height or height for age in disadvantaged children in general. That was the meta-analysis I showed you that essentially concluded that if you look at CCTs in general and UCTs, there's no effect on height. They did find that for girls there was, and also for the disadvantaged, however you would define that. And the question about compliance, I would say I can't answer from the perspective of the Mexican program because it has a very high compliance rate. It's reported at 97 or 98% of compliance, and the explanation for why the compliance rate is so high in comparison with other cash transfer programs is that it's one of the largest cash transfer amounts. Now, with respect to the living wage questions, I want to point out that it's a much more complicated or multi-factor intervention, which is it wasn't just the 3x increase in wages, it was also management engagement, it was more comfortable seating. So this is, again, I seem to specialize in looking at these black box interventions, so I can't exactly say why it's happening, but there's also a component of trying to systematically make the workplace a better place to be. So that's why it's very hard to compare it to other studies that have looked at the living wage. And again, it was also just one factory that was compared with the nearest possible factory that also was producing garments. And I would mention that we did measure subjective social status, back to that question of, is the living wage lifting everybody's? And even though everybody in the factory was improving wages, when you ask the participants about their subjective social status, they definitely perceive that they're doing better compared with their community. So clearly, even though they're comparing themselves and they have this cohort group of other workers who are receiving a living wage, they know that they're doing much better than community members. And I would add, this is my last point, which is tying back to the kind of the unintended consequences of the CCT that we found for adults. I would mention that we're also finding increased rates of obesity associated with being in a living wage situation 1 year later. So that's back to the good news and bad news part of increasing people's income, particularly in a middle income country context, that there are risks that go along with that kind of intervention.
I'd like to this was a terrific panel. Thank every one of you. It was great. And now, I believe at this point the three other moderators come up, and we're going to head into our wrap-up session. I suggest we all stand up while they're moving, but don't leave the room.